Before we begin, I'd like to emphasize that this podcast is an extension of my surgical work and research at Visionary Eye Doctors. And thank you all for tuning in every week or multiple times to kind of hear about our research and how we help patients. And thank you to all of you who have flown in from all over the world to see us here. So I'm very humbled by that. So it is my hope and desire to keep this information free to all of you, especially to my dear patients. And in keeping with this mission, we are very thankful to our first sponsor for this podcast, Wizard Dry Eye Mask. Many of you have heard me talk about the Wizard before. I have loved this product for years. It looks like this. I have one right next to my bed. So does my husband. I used mine last night. And even, if I can't sleep, I'll use it. It's a wonderful product that you just plug in next to your bed or even at your computer. I've been known, if I start to develop a stye, to do the Wizard as I type and then switch, if I have warm, just like a warm compress. So it works wonderful for that. So thank you to the Wizard. If you mention our name, podcast, Visionary Eye Doctors, Dr. Kramer's, they'll give you a 1-year guarantee. If anything happens to the product, just call them up and they'll replace it for you for free. So thank you to the Wizard Research team for sponsoring this podcast. Enjoy. Hi, everybody. It's Dr. Sandy Laura Kramers again. Thank you for joining us for part 2 of Thyroid Eye Disease with Dr. Andrea Laura Kossler, world-renowned doctor, surgeon at Stanford, also my little sister. So I'm so happy to have her on our podcast. We're going to cover in part 2 the risk factors for thyroid eye disease and when to refer, as well as treatment. So Dr. Kossler, tell me about the risk factors for thyroid eye disease.
Yeah, so we talked a little bit in the previous podcast about how to diagnose and some of the common signs and symptoms. And so if you think you have someone that might have thyroid eye disease, yes, it's very important to refer them to, in my opinion, an oculoplastic or an orbital surgeon. And we'll talk about when to do that. And the reason why it's so important is that we want to make sure that we start to manage the risk factors. And so the risk factors for thyroid eye disease, there are some that we know that are not modifiable, right? So things like age, female sex. Females have autoimmune diseases more commonly than men, and it's been said that females have thyroid eye disease a factor of 7 to 9 times more commonly than men. However, when men get it, it's much more severe in men. Other risk factors are patients that smoke cigarettes, patients that have been treated with radioactive iodine. And also, I mentioned age, but for every decade of life, your risk factor for developing thyroid eye disease goes up 17%. There's other things that we think are risk factors, like low selenium levels, low vitamin D, certainly if you don't have your thyroid under good control, diabetes, having very high antibody levels, having sleep apnea, or dyslipidemia. And more recently, we've started to learn a little bit about maybe even certain medications or even vaccines, although that is very, very preliminary and certainly no reason not to get a vaccine. But anything that stresses the immune system or causes hypoxia, there's a lot of reasons out there that we can try to manage some of those risk factors so we can stop the progression of disease. And in a study in Europe, they showed that just using selenium in patients, 100 micrograms twice a day, can decrease the progression to more moderate and severe forms of thyroid eye disease in patients that have early or mild disease by 30%. So there are some things that we can do to try to decrease people's progression and also to treat their symptoms.
So do you give all your patients who have hyperthyroidism selenium?
That's a good question. So only if I thought that they had mild thyroid eye disease. Mm-hmm. So the study was in patients that had mild thyroid eye disease. Okay. Mm-hmm. And then that's a good question because in Europe, they have selenium deficiency in their soil.
Oh, interesting.
Whereas in the United States, there are certain parts of the country that do not have selenium deficiency. Mm-hmm. It just so happens that in my part of California, we do. And so I do prescribe selenium, but it's very much something that depends on geography. I think at the dose that is recommended, I don't see a downside to using mm-hmm. it. And so I do think that it is an important thing to talk about and to consider. And it's also something that the endocrinologist would be more likely to prescribe.
Wow. How about vitamin D? Since you're in California, do you routinely give that or do you check levels or how do you do that?
Well, these questions are great because of the importance of working with endocrinology. And so as ophthalmologists, we can kind of be a little bit honest about the fact that maybe we don't feel comfortable checking vitamin D or checking a hemoglobin A1C or checking for selenium levels, et cetera. But it's so important. So that leads us to the referral question. So I work very closely with my endocrinology colleagues, and I really appreciate their expertise at helping us to decrease risk factors for these patients. So making sure their diabetes is under good control, and checking and determining if they need selenium, checking their vitamin D. And yes, we do supplement vitamin D if their vitamin D is low. And then even treating dyslipidemia. There have been studies that have demonstrated that statin use can also decrease your risk of thyroid eye disease. So working with an endocrinologist so that they can help with some of these risk factors, but most importantly, so that we can make sure that their thyroid is under good control, is super important. So if there's any reason to believe that someone might have thyroid dysfunction, either send them to their primary care doctor or their endocrinologist so they can get the lab workup that's needed. And if there's any concern for them having the eye symptoms that we talked about, and the early ones again would be eyelid retraction, pain, redness, swelling, then you'd want to send to an oculoplastic or orbital surgeon who can really help to make that diagnosis. And I don't want to forget about the later symptoms of thyroid eye disease, because about 25% of patients can present with dysthyroid optic neuropathy. So that's when the optic nerve gets compressed and they can lose vision, even if they don't have any inflammation. So, and about 50% of patients can have the optic neuropathy, even if their vision is 20/20 or 20/40. So 53% can have vision better than 20/40. So let's make sure to check not just the early signs, but even the other things like their vision, their color vision. If you're really worried, you could get a visual field, check their pupils, all of the vital signs that we know about, but always thinking that a patient that you think might have thyroid eye disease could present, although rare, with compressive optic neuropathy. So you really want to do the full exam. Certainly if you thought that a patient had compression of their optic nerve, exposure of their eyes because they can't close their eyes, or any double vision or very severe proptosis, you'd want to put in an urgent referral to an oculoplastic and orbital surgeon.
That's very helpful. We have patients, of course, that have glaucoma and hyperthyroid, and you're kind of always wondering, is it the orbital compression of the nerve that's making their maybe normal tension, normal pressure, glaucoma worse? And so that's kind of difficult. How do you treat those patients that they've had maybe glaucoma before they really developed hyperthyroidism, or at the same time? And is it really a secondary glaucoma, which is nerve damage from the muscle compression? How do you work with those patients?
Sometimes it can be hard, right? So sometimes there can be quite a bit of overlap on two different diagnoses, but that's where all of our tests come in. So getting visual field tests, we know that there are more classic changes with glaucoma versus thyroid eye disease, where you normally will start to see like an inferior visual field defect in thyroid eye disease, although it can present in many ways, versus glaucoma, which I'm not a glaucoma expert, but usually you'll have more of like an arcuate, et cetera. So there are slight differences in the visual field pattern, but also the stigmata of the exam, can help you to go in one direction or the other. But most importantly, the imaging, so CT scan. When you look at a CT scan, you can tell if the optic nerve is either being compressed or if it's tight, if it's a tight apex. So maybe you don't see that the nerve's compressed, but you can see that there's very, very little space, and you could imagine how the nerve could be compressed depending on the direction that the patient is looking. Or you can see if the nerve is on stretch. So if it's really being if the eyes are so proptotic that the nerve is being stretched, that's a less common, but also another reason for optic neuropathy. So getting all of our tests, and even things like RNF-LOCT, which we get for every single patient as well, can help us to figure out which one it is. Is it glaucoma or is it thyroid eye disease? But sometimes it could certainly be both. The other thing that can happen in our thyroid eye disease patients, not to get too complicated here, is that when you have all of this inflammation and when you have these enlarged extraocular muscles, we know that the orbit is like an ice cream cone. So when you put too much stuff in this ice cream cone, then what can happen is the blood flow cannot flow from the outside in to the brain where it's supposed to go. And we call that congestion. So when there's swollen muscles and there's all this fat proliferation and there's all of this soft tissue expansion, then blood flow can't really flow from the eyelids and from the eye out. And that can exacerbate glaucoma or ocular hypertension, because we know that you need to have that uveal scleral outflow, and also just pressure constantly on that optic nerve can impact their visual field changes. So I think it's something that we may need to work with our glaucoma specialists with together to really figure out which it is, or is it a mixture of both? And even more important in our glaucoma patients, to control their soft tissue expansion and their proptosis and that congestion so that we don't worsen that other condition.
It's great. I love the analogy of an ice cream cone. So the idea is that if the eyeball is the actual scoop of ice cream on the top, and your RNFL layer, the retinal nerve fiber layer, is just looking at that kind of back of the ice cream cone as it connects to like this cable that goes through the middle of the cone. Would you agree? So that's a great analogy of the cone is the inner orbit and the ice cream ball is the eyeball itself. And so the congestion within that cone is helpful for patients to understand how it's all connected and why each layer is so important. Now, moving on to treatment, what is I know it depends on you talked about the severity component, and how do you determine the best treatment? I know it's very individualized, but what's going in your brain when you see a patient in terms of treatment? What's the best initial treatment?
Yeah, great question. I actually just came back from a weekend in LA. It was called the International Masters of Thyroid Eye Disease, and we talked about this, all weekend. I don't think we're in an exciting time, let's just say, in thyroid eye disease, where practice patterns are changing and we are experiencing new targeted therapies really for the first time ever. And there's this onslaught of research and investigation into new therapies. So it's a really exciting time. And the landscape of treatment is changing. And I think that's exciting, but it's also confusing. So, I would say that in 2016, the treatment algorithm was very easy, right? YouGo gave us this very nice diagram, and you knew that you would do steroids first line, and radiation was another option, and then there was this IL-6 monoclonal antibody, tocilizumab, and those were kind of our three options. But now, in January 2020, teprotumumab was approved by the FDA in January 2020. And teprotumumab has completely changed the way that we understand thyroid eye disease and the way that we treat thyroid eye disease. And so it's exciting because now we have new targeted treatment options. But it's also our job as, ophthalmologists to try to figure out which patient should be treated with which drug, because we have to think about efficacy, side effects, and, we might want to think about things like cost and convenience, et cetera. So the treatment options that we have after we've done kind of the symptomatic treatments, like let's not forget that we want to treat their ocular surface with artificial teardrops and if necessary, anti-inflammatories, and that we want to control their thyroid and we want to risk factor control, et cetera, and maybe give them selenium. But then after that, if they do really have moderate or severe disease, which by definition means that they have 3 millimeters or more of proptosis based on their age and gender and race. And if they have 2 or more millimeters of eyelid retraction, or if they have moderate soft tissue edema or any double vision. So if they have moderate to severe thyroid eye disease, then we're going to want to treat them with medication. And our treatment options are typically IV steroids, so IV Solumedrol. And that protocol is typically about 500 milligrams for 6 weeks, once a week, and then 250 milligrams for 6 weeks, once a week. So that's kind of the first line treatment that was recommended by YouGo back in 2016. So that's one of our options. That's been the tried and true option for years and years and years. And that's an anti-inflammatory that can be very helpful to stop the progression of the disease in 80% of patients and to treat their inflammation. Another treatment option is orbital radiation. This has been shown to be effective at improving double vision and inflammation, particularly when patients are treated very early in their disease, so like within the first 6 months. If you're treating them too late, it doesn't seem to help. And then I talked about tocilizumab. That's an IL-6 monoclonal antibody. It helps with inflammation as well. But the new kid on the block, or I shouldn't say new, I mean, this is 2025 now, and this came out in January 2020, is teprotumumab, a monoclonal antibody to the IGF-1 receptor. And I mentioned already that the IGF-1 receptor is one of the autoantigens that we think could be responsible for this disease. So it's been really incredible, this drug. I mean, it's really effective, and it can really target the cause of the disease. So teprotumumab has really replaced steroids in many people's hands as the first line treatment. And there's, of course, controversy there. But the way I think of teprotumumab, and I tell patients, it's extremely effective for the properly selected patient, and it's powerful in good ways and bad. So if you have a patient that has active, moderate to severe thyroid eye disease, typically the drug works well. I mean, great, actually. The clinical trials demonstrated that 83% of patients had at least 2 millimeters or more improvement in their proptosis. They had a significant improvement in their inflammatory score, the CAS score. And then about 70% of patients had improvement in their double vision. And they had really positive quality of life improvement scores. Those are unheard of numbers for any of the drugs that we have. Unfortunately, steroids or radiation, they don't improve proptosis, and steroids doesn't improve double vision. So this is the first drug that not only shut down the inflammation and stopped the progression of the disease, but also seemed to reverse some of these very debilitating signs and symptoms. And so it really just completely blew all of us away. And so it's great that we have this wonderful and powerful drug. However, as we've started using the drug, since January of 2020, we've learned that the IGF-1 receptor is ubiquitous throughout the body and is so important for so many functions throughout the body. And the shutdown of IGF-1 for 24 weeks can result in side effects. And the clinical trials were pretty good about explaining which side effects those are. So some things that you can kind of expect and are mild and usually reverse after stopping the drug are things like muscle cramps, hair thinning, fatigue. Some patients lose a little bit of weight, which no one ever complains about, and that's a great thing. Dry skin. But other things that we do worry a little bit more about are things like hyperglycemia. So in the clinical trials, they found that happened in about 10% of patients. And then after the clinical trials, we're seeing that might happen a little bit more, maybe even up to 50% of patients. And then things like hearing changes. So in the clinical trials, they found that about 10% of patients had hearing changes, but 0 in the placebo group. So that was clearly a real thing. And then after the clinical trials, we're finding that number might be a little bit higher. And so hearing has gotten hearing loss has gotten a lot of attention. And I would quote Ray Douglas's study. Ray Douglas is a friend and a brilliant oculoplastic surgeon and researcher. He did a study that showed that if you have normal hearing at baseline, your risk of developing significant hearing changes with teprotumumab was 3%, which is relatively low and something that we can certainly monitor and manage. But if you had baseline hearing loss before starting teprotumumab, that risk was closer to 50%. Mm-hmm. So much more concerning. Mm-hmm. So we've learned now that there are some serious side effects, but I feel very confident in knowing that I can still treat patients safely if I pick the right patient. And so we have to be very careful in selecting patients and screening them at baseline and then monitoring them through the treatment. And I do think that we can use this drug very safely and effectively. But the other great thing is that there's all these new drugs that are coming out. So hopefully we will have newer targeted biologic treatments that are more safe and potentially, either more effective or just as effective.
So you do a baseline audio test or hearing test on all your patients. Mm-hmm. And if there's any hearing loss, you don't use it or you just warn them?
Another good question. So, most answers in thyroid eye disease are, it depends. Mm-hmm. And I like to think of that as customized therapy to our patients because every single patient is completely different. Mm-hmm. So yes, I get an audiogram on every single patient before treatment. And that's very important for everyone to know because not only do we need to treat our patients safely and effectively, but the FDA has put that in the label, which means that you have to check their hearing. Mm-hmm. So yes, we get an audiogram before treatment on all of our patients. And then I will repeat it, usually at dose 4, and then after treatment. If any patients have any changes in their hearing, then of course I'll just check the repeat audiogram at that time. And I would stop therapy until I got a chance to check their hearing. Mm-hmm. So at baseline, we want to check their hearing. And then we also get a variety of labs. I like to get a hemoglobin A1C, a blood sugar. I check their thyroid function tests and their TSI. And that's kind of the baseline of what I'll do. And then I'll repeat that after dose 4, which means week 12, and then when they're done with the treatment.
And so is the hearing loss completely reversible in all patients, or are there some patients that they have permanent hearing loss afterwards?
We don't know if it's reversible. It doesn't seem like it's reversible in a subset of patients, but we don't know really who it may improve for and who it will be permanent in. Just anecdotally, we know and we've seen patients that have had hearing decline. And I have had some patients where after another year or so, you repeat those audiograms and there has been improvement. But I've also had patients that it has not returned. So I think that what we need to tell our patients is that there is a risk that you could lose hearing, and there is a risk that you can not gain that back. So it could be irreversible. Mm-hmm. The other thing we don't know is there a cumulative effect? So, we just don't know these things. And so educating our patients on that risk is important. However, when a patient has very severe disease, and you don't have anything else that can be effective. I've had patients that I've treated with steroids, tocilizumab, radiation, even surgery sometimes, and yet I still can't get them under control and they have very severe disease. You always have to weigh risks and benefits. So the 3% risk of someone having some measurable level of hearing loss that may or may not be reversible. Mm-hmm. But then the risk of someone that has very severe disease or impending compressive optic neuropathy, and then that risk of them losing vision, you really just have to involve your patient. And in these uncharted territories, we really just need to weigh the risks and the benefits as we do for every single thing that we do in oculoplastics. And what's great about working in a multidisciplinary team is that I acknowledge I don't have the expertise in hearing loss. Mm-hmm. But my ENT colleagues do. And so I will treat with my ENT colleagues. I'll involve our audiology team. As I mentioned, we involve our endocrinologist. And so thyroid eye disease is a team sport, and we can really give our patients the best possible care when we're involving the experts that do know the answer, or at least know the best science that we have available.
Mm-hmm. And when patients are super severe and they're starting to have vision loss from compressive optic neuropathy, and they're treated with either one of the biologics or even steroids, can the vision come back? Can the visual field actually come back to normal?
That's a great question. So yes, actually. So that's great, right? So important for us to diagnose these patients early. It's just, we learn so much from our patients. Honestly, I've become so invested in this disease because of my patients. I can think of so many that have kind of changed my life and made me really change the way that I practice or see this disease. And so we have to listen to our patients. We really just have to listen to what they're telling us. This is not aging, people get told all the time, oh, it's just aging, or you just have allergies. They know this is not aging. This is not allergies. So if you listen to your patients and you diagnose them early, then yes, we can prevent vision loss. We can prevent some of these more severe signs and symptoms. But when it comes to compressive optic neuropathy, if we catch them early, yes, we can reverse even very significant visual field changes. However, as you know, if we don't catch them early, and if they've now had compression for, I have patients that come in and they show me pictures of their eyes looking like this from 15 years ago. Mm-hmm. So if we don't catch them early, and if they've had chronic compression over a long time, there becomes a time when you can't get that vision back. And you can tell that on RNF-LOCT, actually. Mm-hmm. So if you see that their ganglion cell layer is really, really thin, mm-hmm. then you might start to think that this is more chronic, and the chances of visual recovery could be less. So that's good to educate patients, but that doesn't mean we don't try. So of course we would still treat them very aggressively. And compressive optic neuropathy, also called dysthyroid optic neuropathy, is an emergency. So you see that, you want to call your local oculoplastic surgeon. Don't just put in a referral. Give them a call. get them in right away, because you won't know really how severe it is. And so you want that to be worked up. And then the way we treat that, and it's not that common, so that's good. It typically happens in the numbers are 3 to 8% of patients. I'd say 5 is a pretty good number, 5% of patients that have thyroid eye disease. And it actually, just to know the risk factors for that condition, it's more common in men in older age, and smokers, and patients that have had radioactive iodine. There's a few others like diabetes, high TSI, but there are risk factors for more severe disease or progression of disease. So the way that we treat compressive optic neuropathy, it depends on many factors, but if it's a little bit more mild, maybe their visual field defects are more peripheral, their visual acuity isn't affected, then I oftentimes will treat with high-dose IV methylprednisolone. So that's a gram every day for 3 days, or 500 milligrams every day or every other day for 3 days. So there's a range there. It's pretty high dose. And then you would repeat their visual fields and the next week to see if they responded. And if they did, you could even consider doing another round of that. So 500 milligrams to 1 gram every day or every other day within a week. And if they respond, great. But the number of patients that respond it's closer to like 40% or so that are going to respond to IV steroids alone. And if they don't respond, you take them to surgery. That's all based off the UGOGO criteria. But now that teprotumumab has hit the stage, we published a report, and it's well known now that teprotumumab can also treat compressive optic neuropathy. However, the thing with teprotumumab is that there are a certain percentage of patients that have regression, which means their proptosis or their soft tissue expansion comes back again. So you can use teprotumumab as well, but you have to monitor those patients long term. We're talking years and years, because you don't want the disease to recur again. So in short, just send it to your friendly oculoplastic surgeon or orbital surgeon, because it is complex and the landscape's evolving. But we do have ways to treat, and we can, especially if treated early, get their vision back. So that's really exciting, and that's what we're here for.
Wow, that's amazing. And thank you also for all the contributions you have personally made in terms of your publications. I know you've published in some of the top journals in the country and in the world, and you have definitely moved the needle in terms of understanding this disease. So that, on behalf of all our patients, thank you for that, Dr. Kossler. So anything you want to leave us with in terms of what you're working on, the latest issue research, and maybe other things that you want to tell everybody about?
I think what I'll leave everyone with is that, as I mentioned, it's an exciting time in thyroid eye disease. And what we didn't talk about are the dozens and dozens of clinical trials that are currently ongoing, because we are exploring many new treatment options to treat thyroid eye disease. There are clinical trials looking at oral drugs, so oral small molecules. So you just take by mouth a pill to treat this disease and to target the IGF-1 receptor. There are new IGF-1 monoclonal antibodies that are being investigated that are either given in your veins or even the subcutaneous injections. And then there are a variety of other medications that are focusing on maybe one of the cytokines that we discussed, or even something called an FcRn receptor. That's complex, but it's another way of trying to treat this disease. So the point is that the future is really bright, and there's a lot of research into treating this disease safely and effectively. And I think that the safety margin is so important, because the safer our drugs are, the earlier we will treat. Some of my patients, they don't understand why we don't treat them when they're really, really mild, but it's because of the risk-benefit ratio, right? So as we develop drugs that are really safe, you could imagine in this perfect world just treating patients when they get diagnosed with that thyroid dysfunction, so that they don't progress. And I think we'll get there one day. So it's a very exciting time. And I think for any patients that are listening out there, if you think that you could have thyroid eye disease, just go to your doctor and get the exam, and specifically let them know what you're worried about. Because the earlier we diagnose, the better patients do. And if you do have thyroid eye disease, we have great treatment options for you. So don't despair. Just go see your doctor. Don't ignore it. And hopefully we can take good care of you.
That's great. Thank you so much. Hopefully when more stuff comes out, you'll join me back on this podcast and we can talk again. Great. Thank you so much for joining me, Andrea. So thank you, everybody, for joining us for the Eye Show. Please subscribe, send it to friends and family, and give us a thumbs up on YouTube and everywhere else you hear this podcast. Thanks again, Dr. Kossler.